All right, well, good morning. Welcome to the Health and Human Services Committee. My name is Senator Ben Hansen, and I represent the 16th Legislative District in Washington, Burke, Cumming, and parts of Stanton counties. And I serve as chair of the Health and Human Services Committee. I would like to invite the members of the committee to introduce themselves, starting on my right with Senator Ballard.
Bo Ballard, District 21, Northwest Lincoln and Northern Lancaster County.
Michaela Kavanaugh, District 6, West Central Omaha, Douglas County.
Murph Rippey, District 12, which is Southwest Omaha, and the good folks of Ralston.
We're missing a couple senators today because last night was a little rough, so I think they might still be recovering. So also assisting the committee is our legal counsel, Benson Wallace, and our committee clerk, Christina Campbell. And our committee pages for today are Krista and Matea. I just feel like I'm going to pronounce that wrong. So, okay. A few notes about our policy and procedures today. Please turn off or silence your cell phones. We will be hearing 4 bills this morning. They'll be taken in the order listed on the agenda outside the room. On each of the tables near the doors to the hearing room, you'll find green testifier sheets. If you are planning to testify today, please fill one out and hand it to Christina or one of the pages when you come to testify. This will help us keep an accurate record of the hearing. If you are not testifying at the microphone but want to go on record as having a position on a bill being heard today, there are white sign-in sheets at each entrance where you may leave your name and other pertinent information. Also, I would note if you are not testifying but have an online position comment to submit to the legislature's policies, that all comments for the record must be received by the committee by noon the day prior to the hearing. Any handouts submitted by testifiers will also be included as part of the record as exhibits. We would ask if you do have any handouts that you please bring 10 copies and give them to the page. We use a light system for testifying. Each testifier will have 5 minutes to testify. When you begin, the light will be green. When the light turns yellow, that means you have 1 minute left. When the light turns red, it is time to end your testimony, and we will ask you to wrap up your final thoughts. When you come up to testify, please begin by stating your name clearly into the microphone, and then please spell both your first and last name. The hearing on each bill will begin with the introducer's opening statement. After the opening statement, we will hear from supporters of the bill, then those in opposition, followed by those speaking in a neutral capacity. The introducer of the bill will then be given the opportunity to make closing statements if they wish to do so. And on a side note, the reading of testimony that is not your own is not allowed unless previously approved. And we have a strict no prop policy in this committee. So with that, we will begin today's hearing with LB 451 and welcome Senator Brewer to open. Good morning.
Good morning. Thank you, Chairman Hansen. Good morning. Seems like afternoon. Fellow senators, the Health and Human Resources Committee. I'm Senator Tom Brewer, for the record, as TOM BREWER. I represent 11 counties of the 43rd Legislative District of Western Nebraska. I'm here today to introduce LB 451. I'm introducing this bill on behalf of rehabilitation hospital clinics across Nebraska. I also have some firsthand experience with these facilities. LB 451 provides direct appropriation for Madonna to pay for capital reconstruction and improvements. To give a little background, I was first, I guess what you'd say, connected with Madonna just after being wounded on December 16th, 2011. I was in Afghanistan and was injured by a rocket-propelled grenade. Because of the nature of a grenade, you have many injuries. And when the military looked at a place to send me that could deal with the loss of hearing, loss of eyesight, partial loss of the use of my legs, injuries to the entire right half of my body, and having my left thumb partially disconnected, they determined that Madonna was one of those choices because it had the ability to do occupational therapy, physical therapy, speech therapy. Oh yeah, you also get a traumatic brain injury thrown into that mix. And it had the ability to deal with the vision, the hearing, all of that. It was one-stop shopping. And when the military looked at across the country, they determined that Madonna was going to be the best place for me to go through treatment. And that started about a 2-year process to essentially get rebuilt. So there were days that you would have 4 or 5 different encounters with different folks within the facility itself. The result of those injuries caused multiple surgeries. So the beauty of Madonna was, as soon as you went through that particular medical procedure, you would come back and then they would start the next phase of either occupational or physical therapy. And then they could also follow on tracking the traumatic brain injury and your progress there. And for those that aren't familiar with it, you hear the term speech therapy. Speech therapy, you assume that has to do with speaking. It was really more about memory loss, memory confusion, all that comes with the traumatic brain injury. So hopefully you understand why after 2 years of time in a facility, you become to feel kind of like part of the team, part of the, I guess, family there. I kind of would compare it to Cheers. And when Norm walked in, everybody knew your name. So that was refreshing when you're going through that kind of trauma. So that's the connection to Madonna. And that's why when I was approached about this bill, I didn't hesitate to embrace it because I had enough personal experience. And, you know, my injuries really weren't that great compared to many that are in Madonna. You walk through there and see those that have been in traumatic car accidents, those that have had really harsh strokes, things like that. And you appreciate that your injuries really were something that were fixable and you could return to a relatively normal life. There are those that struggle immensely. And that's more what I wanted to stress today in this opening was that there are those that need specialized care in a nursing home. And certain facilities are able to provide specific needs. The other part of that is many of the patients don't have private insurance, and Medicaid pays a lot of the bills. Madonna treats everyone equally. Madonna is the only nonprofit nursing home facility that provides specialized care for patients on ventilators. They work hard to wean those on ventilators off, obviously for obvious reasons. Rehab at Madonna is not easy. There were days that I dreaded going in to see a physical therapist or occupational therapist because many times your injuries, you want to return to normal, but in order to do that, it means a lot of work, a lot of time, a lot of effort. As a state senator, I'm concerned about saving money for the state. Madonna loses over $4 million a year on long-term nursing care. If Madonna is unable to afford to continue to provide these complex specialty care, especially as an acute hospital care, they'll be forced to not provide this. And the reimbursement rate for Madonna is higher for Madonna. And so as we go through today and you have a chance to have folks kind of better explain the ins and outs of why this is critical, and I believe the CEO of Madonna will be here today also. Ask questions, try and better understand it. But what I'm here for is I guess to share a little experience that I had at Madonna and why I felt this bill was important and wanted to be the sponsor for it. So this time I'll take questions and I do plan to stay for the close.
Thank you, Senator Brewer. Are there any questions from the committee? Yes, Senator Repeat.
Thank you, Chairman Henson. And, Senator Brewer, thank you for being here. I don't know whether people know it or not, and I've lost count of how many Purple Hearts you have, but I think it was around 8 or so, something in that neighborhood. So you're a walking target, obviously, and a hero in my mind. One of the concerns that I do have is, you can respond to this, pass on, is that my experience is one will get person 10, you know. I mean, so providing some carve out for Madonna creates a lot of other wannabe needs that will come forward either this, not maybe this session because they're not there, but in future sessions. And at the same time that organizations that are asking for this, in like this one, 30 million, they're also asking for Medicaid rate increases. I don't know.
Well,
It's a choice between
they
the two.
are unique in this umbrella under with the nonprofit part. And and some of the specialized care they provide. But I think as far as getting into that area, I'm going to reserve that for the ones that actually watch the checkbook and understand it, because I think I start tiptoeing in a place where I'm not an expert. I guess I'm more here to validate the facility, the care, and what I've personally experienced.
I mean, one more question. How was the food?
Food was good.
Okay.
Food, compared to Army food, it was great.
Okay. Okay, thank you, sir.
Any other questions in the committee? I have one. I saw a fiscal note and they need to implement this, which I wouldn't think, to go through the application process, support the program, $57,000. The department said as a fiscal note, on top of 30 million. It's like $57,000 to be an employee to operate this.
Keep in mind that the fiscal notes sometimes are kind of difficult to understand the logic behind them. So that's a fair question, but again, understanding what goes into the decision on what number they put on a fiscal note, I've yet to sort out.
Yeah, I just thought that was quite a bit of money on their end, I thought. So, all right, you guys ready to close?
Yes.
Okay, all right. Well, with that, we'll take our first testifier in support of LB 451. Welcome.
Thank you. Chair Hansen and distinguished members of the committee, my name is Paul Donjilli, Dongilli, and I am President and CEO of Madonna Rehabilitation Hospitals. I know yesterday was a very long and difficult day for you, so thank you for letting me be here today and allowing me to speak to you about Madonna and the importance of this legislation. Before I continue, I would like to offer sincere thanks to Senator Brewer for introducing this legislation, LB 451. As you all know, he's a proud veteran and a former patient with multiple inpatient stays at Madonna after sustaining the injuries he described serving our country. He's a great ambassador for Madonna's mission and vision. Madonna is a not-for-profit rehabilitation hospital with an attached long-term care nursing facility that's very unique. We're the only such entity in Nebraska. We were founded by the Benedictine Sisters in 1958 as a nursing facility. In 1985, Madonna partnered with DHHS to increase the medical complexity of individuals admitted to the nursing facility with a program to care for individuals with complex medical needs on a ventilator. In 1985, Madonna's nursing facility was the first facility outside of an acute care hospital to provide care for individuals on a ventilator, and today is only one of 2 institutions in the state that provide this chronic ventilator care program. In addition, Madonna is the only nursing facility in Nebraska with a special needs unit in contract with DHHS to care for clinically complex patients. Presently, Madonna has a 126-bed nursing facility, and 30 beds have been dedicated to these levels of care. We serve the highest number of ventilator-dependent residents in the state of Nebraska, and using DHHS CMI, which is a measure of severity of illness, for our ventilator-dependent residents at Madonna, they have the highest CMI of any nursing facility in the state. Without Madonna, these patients would need to be treated in an acute care hospital. We've long focused on meeting community needs and accepted patients regardless of payer source. 76% of our long-term residents in the nursing facility pay for their medical care through Medicaid. Despite the challenges associated with this clinical population, we have received accolades from the state, from CMS, and in 2020 received the COVID-19 Heroes Award for exceptional care and low COVID-19 infection rate during the pandemic. The lower Medicaid reimbursement rate for rehab hospitals makes us a more cost-effective option for patients who need this complex care. Over the last 9 years, Madonna has prevented medical complications and successfully weaned 40% of nursing facility residents on a ventilator, resulting in a discharge to a lower level of care or to the community. This has saved the state nearly $40 million in Medicaid reimbursement over this 9-year period. We have not shared in this cost savings, and the high percent of Medicaid reimbursement presents a significant financial challenge to Madonna, putting pressure on facilities like ours to maintain our infrastructure and provide this care. Since 2015, Madonna's nursing facility has experienced a net income loss every year, and in 2022, this loss reached a high of $4.5 million. We are willing to shoulder some of this burden as it is our mission. However, this reimbursement and cost gap has limited capital dollars for facility renovations and infrastructure upgrades. Madonna is not alone with this financial challenge. In the last 5 years, 15% of Nebraska's nursing facilities have been unable to sustain operations and have closed. Madonna's nursing facility is located in a building that was constructed in 1971. Although there have been facility upgrades to portions of the building, much of the infrastructure is original. The $30 million will allow us to renovate and upgrade 61,457 square feet of ancillary treatment space, resident bathroom, shower facilities, and common areas. Existing air handling, HVAC systems, and mechanical rooms will be replaced at a cost of $3 million. The renovations cost $27 million. As you know, Madonna recently spent $61 million constructing a new patient tower at our Lincoln campus and $100 million constructing a new hospital in Omaha. No state funding was requested for these projects. Requests for state funding for programs that serve a large Medicaid population are common. And I'll reference the Hospital for Special Care, a chronic disease facility in New Britain, Connecticut, provides care similar to Madonna's. They recently received $10 million grant and aid Connecticut state funding to construct a new 12-bed unit. Like Madonna, they have 75% of their inpatient population funded through Medicaid. We're requesting your support for LB 451. We view it as an investment in our facilities so that Madonna can continue to provide a high level of cost-effective care for years to come.
Thank
Thank
you,
you.
Mr. Doncheely, for your testimony today. Let's see if we have any questions from the committee. Yes, Senator Ballard.
Thank you, Senator Day.
Yeah.
Thank you for being here. Can you talk a little bit about some of the challenges of Madonna, maybe just long-term healthcare in general?
Right. Well, I think one of the key ones right now is the rising costs that we see associated with our workforce, and the inability for rate increases coming from federal programs like Medicare and Medicaid that are inconsistent with the rate of increase that we see in order to provide that care. 76% of our costs at Madonna are tied to our employees. We have a large employee base to provide the kind of care that we do. And so workforce challenges and the cost for maintaining employees is out of pace with the reimbursement rates. And so as a result, we don't have dollars often to funnel back into infrastructure improvements.
Thank you. And then if I may,
Yeah.
and then can you talk a little more about, I know Madonna does a great job of private investment. Can you expand on that a little bit from just private donors?
I'm sorry, really.
So private donors, can you expand
Yes.
on that? I know Madonna does a great job of having
Uh-huh.
partnerships with private donors. Can you expand on that a little bit?
Sure. We've long had the support of the community to provide the work that we do. And I think most of our donors recognize that there are aspects of care that we provide that are not funded through reimbursements through either insurance companies or Medicaid or Medicare. For instance, our pediatric program. We have special education teachers that work to help transition kids that we serve back into the school system. Insurance companies say, we're not going to pay for that. That's the responsibility of the school system. School systems say, that's not our responsibility. That service is provided within a hospital. That's part of your insurance package. So no one pays for that. I think a lot of our donor base recognize those specialty services that we provide and give us dollars to help support those aspects of our program that have a huge benefit to the people that we serve.
Thank you.
Senator Kavanaugh.
Thank you. Thank you for being here. We have a letter of opposition from the Department of Health and Human Services, which I don't necessarily see if they're going to testify. So I wanted to give you the opportunity to speak to their opposition, which is basically that they haven't done a grant like this before. That coupled with the fiscal note, which I would echo some of Chairman Hansen's statements seems a bit high on the administrative side of things.
Mhm.
I previously worked in nonprofit fundraising, and that's more than you would pay somebody to be a full-time grant writer. So
Uh-huh.
to administer a grant, that seems pretty high, steep. And I just wanted to give you the opportunity to speak to that. And I also had some questions about maybe some alternative pathways and how we could work on this, perhaps have a cap on what the department can spend, and then perhaps the remaining part would be paid for out of the grant. So if we said that the department can spend $25,000 to pay somebody, an employee to do this work, and if they had to pay more than $25,000, perhaps the remainder of that would come from the 30 million. Is that something that would be workable for Madonna? And
Yes,
just
it
like,
would. It
I just loaded a lot on you.
Yeah.
But go.
No, well, I don't understand or have a good handle on the scope of DHS's involvement in terms of administering it. But we've always been such good partners with DHHS, and I'm confident that the scenario that you outlined, that we could somehow work to absorb that within the $30 million grant request.
So
funding
there's
request.
possibilities moving forward to help adjust and address that fiscal
Yes.
note outside of the 30 million.
Yes.
Okay. So yeah, their opposition struck me a little bit more, as this is more of an observation, as perhaps neutral testimony, but they did submit it in opposition, and so I wanted to make sure you had a chance to address that.
Yeah, we've been such good partners. And like I said, this program was developed with strong input from them and recognized by them as being critical.
Okay.
Yeah,
Well,
thank
thank
you.
you.
Senator Reapy.
Thank you, Chairman Hanson. You noted that in 2022, you had a 4.5 million loss.
Yeah.
My question would be is what's your current bond rating?
Our current bond rating,
Say for the 100 million that I assume you didn't pay cash for that.
correct, we did not pay cash. We just had our latest Standard & Poor's review, and we were rated A- stable.
A minus.
Stable,
Okay, so that's a good rating.
yes.
Okay. The other question that I had was what percentage of your patients are Medicaid? And then if you could, what percentage are Medicare? Do you have that breakdown at the tip of your tongue?
I do in the nursing facility, the days, reimbursed days for care that we provide in the nursing facility, 76% are Medicaid.
76%.
76% are
That's
Medicaid.
big.
I don't have out of the remainder, 24%, the majority of it would be Medicare, and there's a small commercial mix for the nursing facility.
Do you think that high percentage of Medicaid is due because of pediatrics?
No.
No, okay. I guess that one of the things that the hospital industry, I think, or at least some that I've talked to, some administrators, is that one of the biggest ways the state can help is for provider rates, which would then maybe particularly to nursing homes,
Mhm.
to alleviate so that you don't, and they don't get the responsibility of keeping patients in their facility after the funding has stopped. I don't know, I know that happens with Medicare. I don't know whether that happens with Medicaid. We're pretty generous with Medicaid, so maybe we continue to pay anyway. But my point gets to be is, can we do the hospitals like your own more by helping nursing homes? You see what I'm saying? Trying to move people through the system to get them placed.
Right. That was just on the news yesterday. The Nebraska Hospital Association talked about the backlog of individuals in acute care hospital because of the inability to place those folks in post-acute settings or nursing facilities. We've long been committed to this level of care. We do have challenges with staffing right now.
Sure.
And even though reimbursement rates might go up, those reimbursement rates really only allow us to pay our staff a salary that keeps them. You know, nursing assistants make just as much money as fast food workers. And when you look at the scope of the work that they provide, most folks will say, I'll go work at Amigos fast food versus provide or support the care in our nursing facility. We really view this request as an investment in the infrastructure. Regardless of increasing reimbursement rates, the difference between what we're paid and what it costs us to provide service is not going to allow us the dollars that are needed in order to improve the infrastructure of the facility. And like I said, we did not ask any state dollars when we did this for the hospital portion of Madonna. We recognize that's part of our hospital business. It's reimbursed differently, and the mix of payment is different. The nursing facility is another business line or consideration. If we did not do this, we have currently in-house in the nursing facility 90 residents who the state would have to find placement for somewhere else, and a significant number on ventilators. And they would wind up back in acute care hospitals. So we're just asking for an investment in the infrastructure. The first time we've done this in the 60 years that we've been in operation.
Yes, sir.
One more question. What would you suggest we tell other healthcare facilities? Because there will probably be a lineup that say why we selected Madonna to receive, I'll say 30 million,
Mhm.
you know,
Right.
because we would have to, one will get you 10, we'll have to answer that question. If
Yeah.
not this session, and next session, there'll be a lineup in the parking lot.
Right. I can understand that. I think how I would respond is that we provide a service to the state, to state Medicaid. We do. If we didn't do this, they would have to find it someplace else. We viewed this, has long viewed what happens in our nursing facility, and specifically for our ventilator-dependent program, as a partnership. The state was well aware of what we were doing and supported us doing it. So we view this as a partnership with the state and providing them a needed service. We think that is different than the majority of other healthcare facilities that might come to you requesting similar funding.
The Med Center might argue with that, but okay, I'll
Oh.
accept your answer.
Yeah.
Okay, thank you, Mr. Chairman.
Any other questions from the committee? All right, seeing none. Thank you for coming to testify.
Yes, thank you.
We'll take our next testifier in support of LD 451.
Good
Welcome.
morning.
Morning.
My name is Jane Pickle, spelled Pickea. And I've been a resident at Madonna for approximately 6 years. When I was 18 years old, I had a spinal cord injury resulting from a car accident. And despite this, I was determined to have a full life. And as I've lived at Lincoln all my life. And I earned my bachelor's degree in counseling from the University of Nebraska and lived independently. However, years later, a second car accident left me with additional health challenges, which required me to be on a ventilator with a tracheotomy. I need special care and long care to long-term care. And I'm not done because of its mission, expertise, and how well they treat their patients. Thanks to Madonna's exceptional staff, I'm stronger than I was when I first arrived. And I only need a ventilator support at night. Other facilities do not have the activity programs and acute nursing care that Madonna offers. Madonna goes beyond just healthcare. When my mother passed away last year, Madonna made it possible for me to go see my mother before she died. I also enjoyed several of Madonna's groups, outings in the recreation department, and that includes outings to go shopping or go to movies. And I'm very involved in all the activity programs. And I'm also the president of the Residents Council, which is a group of residents who provide feedback to Madonna's staff. If we have any complaints or problems, we address them at that time. The proposed additions, including new bathrooms, will be a welcome improvement for the residents who each need specialized equipment and accommodations. Madonna is my home. I consider it very homey there and have lots of friends and people that I'm pretty close to. I'm grateful for the tremendous care and the activities that they provide. Do you have any questions?
Thank you for coming to testify.
Thank you.
Are there any questions from the committee? Senator Kavanaugh.
Thank you. Thank you for testifying. You're the president of the Residents Council, so you're kind of a politician then.
Well, not really.
You're in the right
I'm not very
building.
good at that.
I don't know. You're here testifying in front of the legislature. If Madonna were to close, where would you go?
That's a good question. The only other nursing home in town is called the Ambassador.
And do they?
They have a ventilator assisted unit as well. But they do not offer extensive recreation, the support that Madonna offers, and the individualized care that's needed for each person. So I was at Ambassador at one time,
Okay.
and they don't do very many activities. They don't have in-house activities, and they do outings once every 3 months. So Madonna does activities, outings every month. And also they'll work with you individually in your room. Particularly during the pandemic, they came to the unit when we were isolated from other units, and they helped me pass the time by playing cards and doing other activities that I like to do. So,
Thank you.
Any other questions from the committee? Seeing none, thank you for coming.
thank you.
We'll take our next testifier in support.
Thank you for allowing part. My name is Scott Wurderman, SCOTTWURDEMAN. Thank you for allowing me to speak today on behalf of Madonna's Nursing Facility. I have been at Madonna president for roughly 17 years. A car accident in 1992 left me with a spinal cord injury. For several years after, I lived with my parents in Columbus, Nebraska. Then in 2006, I came to Madonna for its assisted living services when my dad developed Alzheimer's. My mom couldn't take care of both of us. A family friend who worked at Madonna at the time recommended the program to me, and I'm so glad he did. The staff here are wonderful. They're like another family. I've gotten close to quite a few of them over the years. I'm also appreciative of the specialized ventilator care at Madonna. Also, many of Madonna's staff are wound care experts to focus on prevention and the long-term management of wounds. They are right on top of any skincare issues, which could be a big problem for people in wheelchairs. Plus, they have a physician assistant on the unit. You can talk to them about anything. The planned additions, including new heating and air conditioning, common areas and bathrooms, are needed for the quality of life for each resident. In closing, I like the outstanding care we provide at Madonna.
Thank you for coming and testifying. Are there any questions from the committee? Seeing none. Thank you.
Yep.
We'll take our next testifier in support of LB 451. Is there anybody else wishing to testify in support? All right, so with that, is there anybody wishing to testify in opposition to LB 451?
Bring your own.
I was waiting to hear from you, Bert. Full service. Anybody wishing to testify in opposition? All right, seeing none, is there anybody wishing to testify in neutral capacity? All right, seeing none. With that, we'll welcome up Senator Brewer to close. And for the record, we have one letter in opposition from the department, from DHHS. And no letters in support.
All right, thanks to those who came to testify. I want to start by saying I think that Senator Kavanaugh is right about a technique that is used by the executive side of the House to kill bills that they don't like. And I say that because I've seen it in ag, I've seen it in natural resources, and it's really kind of a sad way of doing things because it isn't about whether the bills are right or wrong. It's an inconvenience or something they don't want to deal with. You put a big enough price tag on it, I don't care how good or how bad the bill is, it will have life. And that's a technique that I think at some point we're going to have to take a look at and figure out why that is allowed to happen, because I think they're using a technique to kill legislation because of their need or convenience. And that's a fight for another day. But if you stop and think about the discussion that was just had, reference Madonna, in ways you can compare that to the decision that was made with our mental health system. The decision was made to collapse that system, thinking that we could do that in other ways. And many of those ended up in the Nebraska State Penitentiary. and we're dealing with it there. And I'm not so sure that if we were to sit down and look at the investment Nebraska has to make because of that, and had we had that mental health system continue, we would have been money ahead, and we would have had a situation that was a whole lot more tolerable with our Nebraska State Penitentiary. Now, with that said, we're dealing with a very unique group of folks that don't have many options. And some of these injuries are at a level that their care is something that has to have special consideration. Now, I wish I was a health expert when it comes to some of the questions. I unfortunately am someone who's been a patient of the care and not someone who's had to manage the systems and understand the complexities and difficulty. I came here today because I think their voices needed heard. Someone needs to champion their cause, and that's why I came here today. And I'm asking you to support LB 451. Open for questions.
Thank you. Yes, Senator Kavanaugh.
Thank you. Thank you, Senator Brewer. First, I'd like to say I would love someone to cross-stitch Senator Brewer's quote of Senator Kavanaugh's right. Just putting that out into the universe. I discussed with the director about the opportunities for addressing the fiscal note in creative ways. Would you be willing to work with the committee on that?
Yes, and I think I would also probably say the same thing that I've told the Department of Ag under the previous director and the Department of now, or with Game and Parks, and that is these agencies need to come in neutral, and then they need to provide information, detailed information, justifying why they see a particular concern. To purposely come in knowing full well that that position could very well doom the bill, it's not fair. It's not fair to our committee process. And so, yes, I would do whatever I could to help.
I would say that I stated this before. I believe that their opposition letter is more neutral. It more stated that they haven't done something like this before, which is not a reason to not do something. And I think we could continue the conversation about if there's a more appropriate department. I understand why we would have DHHS doing the grant awarding, but I know other agencies have done grant awards. And so we could probably look at fiscal notes of how they've done that and the cost. And what I'm saying is I look forward to working with you on this.
And it's in the public record that I agree with you.
Marking my calendar.
All right. Any other questions from the committee? All right. Seeing
All right,
none.
I'm off to do interior design.
Thank you. Look at that one. Okay, all right, well, that'll close our hearing for LB 451, and then we will now open it up for LB 433 and welcome Senator Jacobson. This is the first time in front of HHS?
It is. It is.
Right, we've been waiting for it.
Is this chair on the floor? I feel like
No.
Now it's blame Senator Brewer.
I've never felt this short.
It's all for a reason.
I gathered as much. Wow. Well, you guys have a way of really intimidating somebody right out of the gate. Well, good morning, Chairman Hanson, members of the Health and Human Services Committee. My name is Senator Mike Jacobson, Mikejacobson, and I represent the 42nd Legislative District. Today, I'm introducing LB 433, a bill that I believe is absolutely necessary and would seek to provide budgetary flexibility to the 6 regional behavioral health authority regions across the state. LB 433 adds needed budget flexibility for regional behavioral health authority regions to allow local needs to be met. It requires that any appropriation to the regional behavioral health authorities region via the Division of Behavioral Health be allowed to be used within approved annual budgets or by activities identified through need as demonstrated by the region throughout the year. A regional behavioral health authority may move up to 20% within a service category to address emerging needs. If the amount exceeds 20%, a regional behavioral health authority may request a transfer, and a director of the Division of Behavioral Health shall grant it upon unless it violates state or federal law. If a denial is issued, the region may appeal the decision through the Administrative Procedures Act. Last summer, I met with the governing board of Region 2 Behavioral Health in North Platte. The governing boards of our regional behavioral health authorities are comprised of one county commissioner from each of the counties within a region. Region 2 is comprised of 17 counties in west central Nebraska. During my meeting with them, they expressed concerns about the lack of flexibility that the Division of Behavioral Health provided them to meet the needs of our region. My office began researching this issue and discovered that there was not much flexibility provided to the Behavioral Health Services Act for the regional behavioral health authorities. Further, we discovered through additional conversations with Region 2 that even with the Appropriation Committee intent language in the 2023-2024 budget, which is similar to LB 433, there still had not been much desire on the part of the division to be flexible to meet the region's needs. I'm a fiscal conservative. You all know that. That is why I'm passing this. Passing this legislation makes sense. This legislation allows for those folks who are on the front lines in our regional behavioral health authorities regions to work to maximize the dollars we have provided to them to provide the maximum amount of services within their geographic area. This bill does not expend any new money. It provides flexibility to them to move money to specific target areas. In testimony after me, you will hear from representatives from 3 of the 6 behavioral health regions, including Region 2, 6, and 5. Each of them have stories of how the lack of ability to move resources around has caused major issues in their region. 2, you will hear from providers who have experienced the frustration of the lack of responsiveness to needs in both rural and urban Nebraska. I encourage you to listen to them and to join me in supporting a bill that makes a lot of sense and allows for these officials whom our voters have elected to make the decisions they need to make on budget priorities. I can tell you, listing specifically at Region 2, we had a significant amount of conversation about the amount of budget dollars that they were not able to expend, although they had overwhelming needs in the area. I want you to focus on the fact that one size should not fit all. And I want you to also focus on the testimony that you're going to hear from those opposing as the agency in particular. And I'm going to agree with Senator Brewer and Senator Kavanaugh. You're going to get a 2-for-1 today. So you can put me on record as agreeing with this as well. This is a situation where our needs are different. Okay. And one thing I think you've heard on the floor from me is we've got to look at the entire state, and our needs across the state do differ. And I want you to also focus on the idea that 3 years ago, this wasn't a problem. Okay, 3 years ago, there was ability to move money around, and now it's changed. I find it appalling that there's a fiscal note the size that's on this bill. It's disgraceful and appalling to me that to go back to doing it the way we did 3 years ago is going to cost $1.4 million. So with that, I'm going to stop and ask for any questions, and would refer you to the fact that we will have testifiers that will get you into the weeds on the issues that they've had. With that, thank you.
Thank you. Are there any questions from the committee? Senator Reapy.
Thank you. Thank you, Senator. Senator, I appreciate you being here, and I have a keen interest in the mental health piece. What problem specifically initiated this legislative act? I assume there was some sentinel event that precipitated all of it, that finally just blew the lid off of it.
There is, and I'm gonna ask for Kathy Seacrest to give you the specifics, who's the Region 2 director. But I will tell you that when I met with them my understanding there was $1.2 million in budgeted dollars for Region 2 that were frozen and could not be spent because their need, what it was targeted for wasn't a need that we had. We had other needs and we weren't allowed to move the funds. That's when I contacted DHHS through a letter to say, can we sit down and talk? And the answer was basically they weren't going to be flexible. So we've had crickets since that time. I bring a bill, suddenly I get some communication with nobody understanding, well, gee, what's wrong, what possibly could be wrong. So there really been no serious effort to really try to resolve this, and that's why this bill's here today.
The next question, if I may, sure. It seems to me that this is not a bill specifically about Region 2, but rather a major move to totally decentralize the existing statewide mental health delivery planning process or system. And so ramifications on this can be somewhat significant.
I think the goal here is to be able to allow a portion of the budget to be moved around. And I think that's really what we're aiming at. And I think that's where the focus is. I understand that there's various funding mechanisms and we don't want to interfere with those. But I can just tell you that the system, the way it is, isn't working. And I think after you hear the testimony from the other three regions, and the three regions and hear what they're saying specifically, I think you'll probably get a better idea of just exactly what we're seeing there.
Did I hear you say earlier 20%? Someone
Yes,
said in my-
that's what's in the bill.
Okay. Thank you. Thank
Thank
you for
you.
being here.
Senator Kemp.
Thank you. Man, I'm feeling the love this morning.
I'm afraid you're going to hold it against me. I was really hesitant to say this morning.
Never. You did mention something that I wanted to ask you a little bit more about. So you said that this wasn't the way things were three and a half years ago. And according to our wonderful legal counsel's memo, there's no specific past legislation on this issue. What changed?
The contract changed between DHHS and the region.
Okay. And so this is seeking to codify how it was done before the contract changed.
Essentially, yes.
Okay. And I do have questions about the fiscal note as well, but I think I'll save those for some of our regents that are going to testify.
Thank you.
You're welcome.
Any other questions? I have one. Is there any concern that we might jeopardize federal funds?
Well, I think that's the question we've got to work through. I guess my question is what changed? Did our funding change that significantly from the federal level from 3 years ago? And why did this all of a sudden become a change in the most recent contract, but none of this was included in the previous contracts?
All right. Seeing no other questions?
I will stay for a close.
All righty.
Thank you.
Okay, good. All right, we'll take our first testifier in support of LB 433.
Thank you, Senator. We'll see how short I feel.
Thank you for coming. If you could please spell first and last name and compliment Senator Kavanaugh.
Good morning, Chairman Hansen and members of the Health and Human Services Committee.
Welcome.
I'm Kathy Seacrest, KATHY-SEACREST. I'm the Regional Administrator in Region 2, comprised of 17 counties in west central Nebraska. We would like to thank Senator Jacobson for bringing this bill. Historically, the regions were created to keep service delivery local and to have local elected officials determine budget and services. The erosion of that role is why I and other leadership from the other 5 regions are here today to support this bill. Over the last decade, the behavioral health regions have been so tightly controlled by the Division of Behavioral Health that we cannot provide the services needed. The cookie cutter approach that the division is using keeps us from creating what is needed in our own areas and hampers our work with Nebraskans in need. In previous years, we had the flexibility to move dollars where we needed them, up to 20 to 25%. Again, within the last decade, that was taken away. Now every dollar must be pre-approved for shifting, even though the Regional Governing Board, comprised by locally elected county commissioners, has already approved that shift. This kind of state control keeps us from achieving the best outcomes for our consumers. For the first time in my 34-year career with the region, there is money available to us within our budgets to address needs. and I find that a miracle. But we cannot utilize it. In Region 2, it took us over 14 months to create a couple of services that our community forums made up of providers and consumers requested. The money was there, but the hoops that we had to jump through made it almost impossible. The division has virtually destroyed a program that we created over 20 years ago, that someone calling can see a counselor within 48 hours to determine what they need and to access that service. Region 2 created this program, and 2 years ago, the division decided we could only provide it on a unit basis and that each person had to meet all criteria. And our original idea was get the person in, see them, take care of them, and then we can figure out the logistics. We wanted to make that connection with the person who needed services quickly and help them access what they needed with a minimum of paperwork. Under the current requirements, we must collect all the information up front. We get paid a fraction of what the program's actual costs are. The division took over $300,000 away from this program. They told us that we could use it for something else, but the things that we have tried to implement were delayed or denied. We need the flexibility this bill allows. My governing board has met with the division and has tried to make things work, but it goes nowhere. When we asked how to appeal a decision, we were told to email the director of the division who made the decision in the first place. Thus, we also want a way to appeal decisions. My board has requested that we continue expense-based reimbursement. The answer was no. My board asked for a rural rate, and they were told that the division might look at that in a year or two. In closing, mental health and substance use disorder services are needed now more than ever. We want to meet those needs, but our autonomy and flexibility have been eroded. Please pass this bill to help us utilize our dollars as effectively as we can and for the good of those in need. I'm happy to answer any questions you might have.
Thank you for your testimony. Are there any questions from the committee? Senator Kavanaugh.
Thank you. Thank you for being here. Do you feel comfortable talking about this fiscal note?
Would you say that?
Do you feel comfortable talking about the fiscal note? I want to make sure I'm asking the right people about this fiscal note.
I only saw it yesterday,
Okay.
but yes, I'm happy to talk about it.
Well, I just, as Senator Jacobson said in his opening, that this is how it was previously done. And this fiscal note is for it's $1.4 million to go back to how it was previously done. I guess I just want to give you the opportunity to share your thoughts or perspective on that.
I'm flabbergasted by the fiscal note. When we put this in, we did not see it costing anything. Now, potentially, if we had to appeal a decision, that appeal might cost the state something. But in fact, it would cost the division less work because they wouldn't have to be approving every single dollar that we need to shift. So I, Senator, can't really account for the fiscal note.
So, sorry, if this is how you previously did things, and then 3.5 years ago or so, that changed. And Senator
Yeah, a little more than that, and it kept getting tighter and tighter.
And was that through the contract with the
Yes.
state that
Yes.
it kept getting tighter and
Yes.
tighter?
Let me just grab it here. In 2016, 17, and 17, 18, it literally says we can move 20%, 25% actually, here and there. So why that had to change, I don't know. And federal funds have come up. This is usually state general funds. The federal funds, we clearly understand, have to be used for what they are intended for. And all of the regions understand that perfectly.
So the funds we're talking about are state funds, to kind of go back to Chairman Hansen's question.
Most of the, I can't think, the only time it would be federal funds is the substance abuse dollars in prevention, and then we're not moving them out of prevention, we're moving them amongst the categories. And we used to be able to do that with just do it. Now we have to have permission to do that as well.
Okay, thank you.
Thank you.
Senator Reapy.
Thank you, Senator Hanson. I have a couple of questions. One is, do you perceive that the change, I think you said, what, 2 years, 3 years ago?
Well, it's been over the course of the last 10 years, but more significantly in the last 5.
Was that due to a change in DHHS policy or in DHHS leadership? So a different leadership style?
You know, I wish I knew.
Okay.
I know the contracts changed. I know our network operations manual changed, but whether that was from leadership or what, I don't know, Senator.
And you said the feds are pretty uncompromising. I mean, what they say is what you have to do.
Right, and all the regions understand that and follow the federal guidelines to the letter.
So if you're given them 20 to 25% latitude flexibility, do you have an oversight audit plan? I mean, how do
Oh,
you?
we have
make sure that-
audits all the time.
Okay,
Yeah.
okay.
We do a CPA audit and the division audits us, and we audit our programs. So, I mean, there's lots of checks and balances for those funds.
Okay, thank you very much. Thank you for being here. Thank you, Mr. Chairman.
Yep. Any other questions from the committee? All right, seeing none,
Thank you.
thank you. We'll take our next testifier's report. Welcome.
Good morning, Chairman Hansen, members of Health and Human Services Committee. My name is Patrick Kreifels, Patrick I am the Administrator for Region 5 Systems Behavioral Health Authority. I am here today on behalf of the Nebraska Association of Regional Administrators and on behalf of Region 5 Systems Governing Board. Region 5 is comprised of 16 counties in southeast Nebraska, including Butler, Fillmore, Gage, Jefferson, Johnson, Lancaster, Nemaha, Otoe, Pawnee, Polk, Richardson, Saline, Saunders, Seward, Thayer, and York. I want to begin by offering my profound appreciation to the senators and governor for the commitment, sacrifices, and contributions to our state, ultimately helping make Nebraska a great place to live. Thank you for your service. Social determinants of health have a major impact on people's health, well-being, and quality of life. Examples of social determinants of health include safe housing, transportation, education, job opportunities, income, access to nutritious foods, and physical activity. When Nebraskans experience a major mental health or severe substance use condition, oftentimes there's interference with their daily living activities and therefore impacting social determinants of health and quality of life. The regional behavioral health authorities are committed to system and service improvements and as a public safety net for Nebraskans who are oftentimes marginalized because of a major mental health and substance use condition. In order to accomplish these improvements, there is the need to have flexibility in our funding and reimbursement systems and the authority to manage local services. The flexibility that was afforded to the regions in years past has been gradually eroded away, much like the topsoil in our agricultural fields being blown away year after year. This erosion in the behavioral health system has resulted in restricted decision-making with flex funds, lack of or slow responses with approvals for expanding services and adding new innovative services, ineffective restrictive policies, procedures, attempts to have the behavioral health system mirror Medicaid's fee-for-service environment, and questioning that delays approval processes. This lack of engagement, collegiality, commitment, collaboration, understanding that all system partners are needed to fulfill the system needs directly and negatively impacts the people with the most vulnerabilities in our community. With the expansion of Medicaid eligibility rules and enrollment starting in October of 2020, adult Nebraskans with income up to 138% of the poverty level, a household of one who makes approximately $18,000 annually, are eligible for Medicaid. This means more Nebraskans are gaining access to health care to meet their needs and supporting their social determinants of health, and there are fewer people utilizing regional behavioral health funding. This has created a unique opportunity for the behavioral health continuum of care in Nebraska to leverage existing funds to be reinvested in our system, covering the gaps and fragmentation and to enhance, expand, and improve services across Nebraska. Examples of how we have been able to leverage and maximize funding are 2 projects with Lancaster County. Community Corrections is contributing American Rescue Plan Act funding of approximately $2 million to assist with locating a building, and Region 5 Systems is allocating $1.2 million for behavioral health services such as crisis stabilization and mental health respite to serve adults in the community experiencing a behavioral health crisis. This service offers people in our community somewhere to go when experiencing a behavioral health crisis versus going to the emergency rooms or filling up the jails. This service has been released for request for proposal in our community. Additionally, Lancaster County is contributing ARPA funds and allocating up to $6 million to assist with locating a building, and Region 5 is committing another $1.2 million for behavioral health services such as a family resource center to serve families and youth in the community experiencing behavioral health crises. Referral sources will be law enforcement, 988 helpline, mobile crisis response, and families. This service also offers families and youth in our community somewhere to go when experiencing behavioral health crises versus going to the emergency room, waiting for hours, and only to learn that their youth are not going to be admitted and then being turned away with minimal supports. Extremely frustrating for the families. This service continues to experience delays in response from the Division of Behavioral Health since December 7th, 2023. As regional administrators, we work closely with county commissioners from our respective counties in our geographical service area, ensuring they are contributing county match funds for services and listening closely to constituents from rural and urban citizens, taxpayers, and persons of interest to aid in identifying the gaps and fragmentation in our behavioral health system.
Ms. Rebels, your red light went off.
Oh,
A little bit ago.
thank you.
Yep. Do you want to just wrap up your final thoughts like really quick?
I certainly can. I just, when I was listening to Senator Brewer 451 testifying about the jails and the mental health problems in our community, I think that's what we're talking about. Some of our services are here to support the people so they don't have to go to the jails. I just ask respectfully that you support LB 433.
All right, thank you.
Thank
Any
you.
questions from the committee at all? Senator Reed?
Thank you, Senator. Could you help me share with me an example of your interest in a program that's not allowed by DHHS? Say if you had this 25% flexibility, is there a specific program that you would say, this is where our Region 5 community needs that's different than urban Omaha or Lincoln?
I'm going to try to answer that, Senator.
That's all I ask.
What I can say is we want to continue to have a collaborative and collegial relationship with Health and Human Services.
Sure.
And in doing so, we do need their partnership to continue to make sure that the funds are expended in appropriate ways and that we are following the federal guidelines or local, state, and laws. And so I cannot think of a specific example for you today. However, it's that slow response time. When we're looking at on average 78 days to get a response to help move services out in the community. The longest time we waited was 288 days to get a response from Health and Human Services. So this is the challenges that we are experiencing that ultimately affects the people that are vulnerable in our communities.
Okay, thank you. I'm making notes. Thank you.
Any other questions from the committee? Senator Ballard?
Thank you, Senator. Thank you for being here. Kind of piggybacking off of Senator Reepe's question, looking back at your last fiscal year, where would you have moved money with this flexibility?
There are lots of opportunities for us to move money. So looking back over since 2021, April of 2021, we have submitted over 30 requests to the Department of Health and Human Services to shift funds for proposals. And that is on the low side. We monitor the entire array of services, whether it be an acute stay at a hospital or a residential for substance use or mental health or outpatient. And when there is underproduction or overproduction by providers within the network, we need that flexibility to shift quickly for them so that they are being reimbursed in an appropriate time frame. And waiting on average 78 days to respond. It's not a quick response. And that's the concern that we have and our constituents have, increasingly concerned about the bureaucracy and the delays that are occurring in our relationship with Health and Human Services.
Thank you.
Any other questions? All right, seeing none, thank you.
Thank you for the opportunity.
Mhm. Is there anybody else wishing to testify in support? Welcome.
You're right, Senator Jacobson. And I'm pretty short as to start with. So. Good morning, Chairman Hansen and members of the Health and Human Services Committee. My name is Dale Schroeder, DALESCHROEDER. I am a commissioner in Keith County, and I represent District 1 there. And as a result of that, I am a member of the Region 2 Human Services Governing Board. I've served on this board since January of 2021. And I'd like to thank Senator Jacobson for bringing this important legislation. I appreciate the opportunity to appear before you today in support of LB 433. Problems have been building for Region 2 over the past 7 years. We've debated that, whether it was 10 or 3 or 5 or 7, but I'm going to say 7 now. We as a governing board have experienced an extreme loss of control, which has resulted in an inability to get dollars moved to meet the needs of patients in our region. My time on the Region 2 board has allowed me to gain a tremendous amount of respect for the abilities and knowledge of our administrator, our regional administrator, Kathy Seacrest, and her staff. Thus, I am certain that their methods for maintaining care within our budget are well-planned and completely transparent. They have gone above and beyond the requirements that the Division of Behavioral Health has demanded of them. However, the Division of Behavioral Health continues to put up roadblocks that prevent Region 2's ability to deliver services that we know work in our area. The division wants to use a cookie cutter approach to provide services, and in our rural area, that just doesn't work. Our board asked the division to consider a rural rate table, and we were told that they may look at that in a couple of years, but we need to have this happen now if we're going to be forced to bill that way. We need the flexibility that LB 433 gives us to manage our dollars effectively and efficiently. As a board, we've tried working with the division, but they continually refuse to acknowledge our role in the system and our ability to define the needs that Region 2 has. This resulted in the division mandating an external audit, which we complied with, and the third-party audit findings indicated that Region 2 was perfectly in compliance with requirements and regulations. The division's leadership determined that these findings were not to their liking, thus they simply overlooked the audit and continued to throw up roadblocks. We, the governing board and our administrator, asked to appeal the decision of the director. We were then informed that the appeals process was to go directly back to the deputy director's office, thus rendering us helpless in an appeal process. This is simply not acceptable. I know that you are all familiar with the United States Constitution, and Article 1 guarantees its citizens the right to petition the government for a redress of grievances. There must be a fair process of appeals put in place. Region 2's administrator, her staff, and our governing board have been good stewards of the state dollars and use every dollar we can for service delivery to those who need help. I simply ask that you help pass LB 433, which will help our region and other regions continue to do just exactly that. I appreciate your time and attention to the issue, and I'll try to answer any questions that you might have. And I do mean try.
Thank you for your testimony.
Thank you.
Are there any questions from the committee? Come on, you lucked out.
Good. I'm glad the regional administrators took care of some of that for me. Thank you.
Thank you.
I appreciate the opportunity.
We'll take the next testifier in support. Good morning.
Good morning. Chairman Hansen, members of the committee. My name is Patty Jurjevich, P-A-T-T-I-J-U-R-J-E-V-I-C-H. I'm the administrator for Region 6 Behavioral Health Care. I'm here today on behalf of the Nebraska Association of Regional Administrators and also on behalf of the Region 6 Governing Board. For your reference, Region 6 is comprised of Cass, Dodge, Douglas, Sarpy, and Washington counties. We too appreciate the introduction of LB 433 by Senator Jacobson. There are two items I'd like to bring to your attention today. First is to confirm for you the Regional Behavioral Health Authority's commitment to system and service improvements. In November, I appeared before this committee and provided the attached recovery-oriented system of care document developed by the Regional Behavioral Health Authorities. The document provides information on the proposed system changes as we have the unique opportunity to redirect and reinvest funds to enhance, expand, and improve services across Nebraska. Second, in order to accomplish these improvements, there is a need to have flexibility in our funding and reimbursement systems and the authority to manage local services. I do want to note that that attached document, we've had ongoing discussions with the Division of Behavioral Health Leadership since August of 2022. The Regional Behavioral Health Authorities envision a system that is well-resourced, has adequate service capacity, provides services across the continuum, and ensures care to support individual recovery regardless of payer source. At the hearing in November, I indicated in my testimony that an important principle of a recovery-oriented system of care is adequate and flexible funding. Based on apparent changes in the working relationship with the department, the regions have experienced the loss of flexibility and authority needed to effectively manage the behavioral health system to address these needs in our communities. As a result, there has been the steady reduction of the Regional Behavioral Health Authority's ability to respond to individual community and system needs in a timely manner. Slowly and methodically, the ability to serve as the safety net of Nebraskans who experience a mental illness and or substance use disorder has been diminished. The once collaborative, productive partnership between the Regional Behavioral Health Authorities and the department that we experienced during behavioral health reform, unfortunately, does not appear to exist. It is important to remember regional behavioral health authorities have statutory authority and responsibility to develop and coordinate the publicly funded behavioral health services within the region. It was the legislature's intent in the 1970s, with the legislation establishing the regional system, that mental health needs were best determined and decisions best made at the local level. The expansion and requirement of the fee-for-service environment has crippled our ability to be innovative and responsive to needs, both present and emerging. This fee-for-service reimbursement method alone, without the opportunity for supplemental financial support to help cover operational costs, also endangers access, especially in rural areas when providers cannot sustain service capacity. You may be aware that utilization of the appropriation from the legislature to the behavioral health system is low. This in no way indicates there isn't a need for more behavioral health services. It is much more a symptom of the systemic delays and constraints experienced through the department. We respectfully request your consideration of the proposed language in LB 433 that provides the regional behavioral health authorities with the necessary flexibility and authority to make timely budget and service decisions in response to needs in our communities. We recognize the issues facing schools, hospital emergency departments, psychiatric inpatient units, county correctional facilities, criminal justice, law enforcement, and access to care concerns of our citizens. Regional behavioral health authorities are working to move forward plans to reinvest dollars in order to expand capacities and develop new services to address many of these needs. But the process can be a slow one. I assure you that regional administrators are ready, willing, and able to collaborate with the department for the betterment of our system. To conclude, the regional behavioral health authorities envision a system that is accessible, effective, efficient, innovative, and flexible in order to meet the current and emerging behavioral health needs of Nebraskans. As always, we appreciate your continued support of the behavioral health system. I thank you for your time today, and we'll try to answer any questions you have.
All right, thank you for testifying. Are there any questions from the committee? Senator Reapy.
Thank you, Chairman Hanson. First comment, and you can respond to this. It seems to me that this, or it appears to me that this is a coup d'etat, if you will, by the regional behavioral health systems, because it sounds like virtually all of you are here to testify in support of this greater flexibility.
Well, it is an ongoing concern that we have about how we can reasonably and in a timely manner respond to those local needs. It is the regions and our staff that get those phone calls from law enforcement, from the hospitals, from the school systems. They have needs that need to be met. And if we can't respond, if we have the dollars, and we have the dollars to invest in those things, if we can't do that in a timely manner, then we're not being effective at our mission.
Okay. The second question, if I may, Mr. Chairman, was with the demise of the state mental health hospitals in the 70s with the intent that they were supposed to be replaced by community mental health centers. And of course, nice idea, never happened. Were these regional centers set up to be that answer to the absence of the state mental hospitals of Hastings and, I forget, Lincoln, Omaha, or Lincoln,
Norfolk. and-
Hastings, Norfolk?
Correct, yes. I was involved in that behavioral health reform effort. There was a great deal of planning, a great deal of collaboration that went on between the regions and the Division of Behavioral Health. We all put together plans on what we needed to be able to serve individuals in our community so they could return from the state hospital system and perhaps not need to go to the state hospital system and could be served closer to home and families. The unfortunate thing was there wasn't sufficient dollars to do everything that was identified that was needed. So everybody did the best they could with the dollars that we had, but unfortunately we have, continued to see ongoing needs, probably much related to that inadequate funding of that behavioral health reform effort.
You may have known Dr. Frank Mentalocino.
That name is familiar to me. Yes, you bet.
Because he was instrumental in all that too.
Yes, he was.
Okay, great.
Yeah.
Thank you. Thank you, Mr. Chairman.
Senator Kavanaugh.
Thank you. Thanks for being here. The fiscal note talks about needing to hire additional staff to basically make sure that the regions are in compliance with the federal regulations. And since I don't know if the department is testifying today, I'm going to ask you, and if you don't know the answer, that's totally fine, but do they currently check to make sure that the regions are in compliance with federal spending
Absolutely.
guidelines?
Absolutely. That is a role that they have. And we are in regular communication when there is a question that we have about whether potentially, a budget shift that might impact federal dollars or any of the maintenance of effort kinds of situations that go on with federal dollars. We could communicate regularly with them and they can give us an indication whether that's a concern of theirs.
Okay, it's not your responsibility to address their fiscal note, but it seemed to me that there probably were people that work at the agency that make sure that you're in compliance, the regions are in compliance.
That is a correct
currently.
statement, yes.
Okay, thank you.
Senator Walls.
Thank you, Chairman Hanson. Thanks for coming today. Mr. Kleifels said that he had asked for over 30 requests to shift funds. Do you, over the last year, I don't remember if it was the last year or how over the time period, but can you give us an idea of how many requests
How many budget shift requests?
yeah.
I'm afraid I don't have that at my fingertips today. I certainly can follow up with you. And I would say probably our greatest concern is the timeliness of, I can give you an example. A concern that we've had with individuals leaving Lincoln Regional Center. These are individuals that probably have very complex and complicated needs. And we have we don't really have anything in our community that best meets those needs. So we started a process in August of 2021, alerted the Division of Behavioral Health. We need to develop something. We don't think anything else exists like this. We want to develop something. So the conversation started. So, you kind of pitch, this is our idea about how this service might look. And it was clear after some conversations with division staff that they weren't going to approve that. So, the conversation continues month after month after month, trying to figure out what is it that we can create that meets those individuals' needs that will get approved by the division. So that process really took until probably late last calendar year before we were finally able to settle on a service definition that the division would approve. Then we have to submit to the division our request for proposal document. And then that takes time then for them to review and get approval on that. So a process that started in August of 2021, we just in January, late January, were able to have a bidders conference to get the ball rolling, to find out if we have providers that can do that service. In the meanwhile, people are not getting services that they need. We know that. That's where, we have a sense of urgency to try to move things forward, right? It's a little different situation than a budget shift necessarily, but these are some of the major issues that from a time perspective are creating problems for us.
And so you wouldn't have had that issue 3.5 years ago or prior to the contract being changed. You would have been able to define and start a service that was needed.
It may have been just a little bit of a different situation with a new service that doesn't exist already. The shifts are a little easier made between existing services. Maybe you're expanding a service. It is, if you're bringing in a new service definition, it may make it a little more complicated in that process.
Yeah. Thanks.
Any other questions? Seeing none, thank you for coming.
Thank you.
All right, take our next testifier in support of LB 433. Welcome.
Thank you. Good morning, Chairperson Hansen and members of the Health and Human Services Committee. My name is Annette Dubas, ANNETTEDUBAS, and I'm the Executive Director for the Nebraska Association of Behavioral Health Organizations, otherwise known as NABHO. NABHO represents 52 organizations statewide that include community behavioral health providers, hospitals, regional behavioral health authorities, and consumers. We work to raise awareness and build alliances that support access to behavioral health care for everyone across our state. We thank Senator Jacobson for his support of our behavioral health regions and for introducing LB 433. Our members, as well as many behavioral health providers across our state and country, rely heavily on public payers for reimbursement. Medicaid is the single largest payer for mental health services. The Division of Behavioral Health and the 6 regions are one of those public payers that our members engage with regularly. Medicaid is a federal program, which brings with it federal regulations and requirements. There's very little, if any, flexibility when it comes to services and reimbursement from CMS. Providers understand that, and some will even make the decision because of the complexities of the program not to serve Medicaid clients. But the Division of Behavioral Health and the regions are a very different program. Our 6 region partners with their local county governments. Each region has a board with 1 commissioner or supervisor from each county. Counties contribute financially as well, with $1 for every $3 from the general fund. Regions also seek input from consumers through advisory committees and provider meetings. Regions were established specifically to meet those local needs, not a one-size-fits-all like Medicaid. Regions contract and work with the local providers to meet the needs of their communities. Our members sincerely appreciate the flexibility and how responsive that system can be to meet the needs of their clients. Regions are a great example of local control and responsiveness. You've heard more specifics from the region testifiers today, but I want you to know from a provider and a consumer perspective, we truly do appreciate the ability of regions to work with us and support services that meet our community's needs. One of the objectives of LB 1083 that was passed in 2004, which was mentioned earlier, was the closing of those regional centers and the intent to move those resources into the communities through the regions, and again, their ability to assess the needs in specific areas of their communities. For whatever reasons, the flexibility provided with the regions were established has been slowly eroding. NABHO supports LB 433 because our members and the people they serve benefit from that flexibility. I've been in conversations where it was discussed that perhaps we need to more closely align DBH with Medicaid. And while we agree there may be some places that can happen, It's more important to recognize that these are two very different types of programs and payers, each with their own purposes and benefits, and really strongly believe it should remain that way. LB 433 adds needed budget flexibility for regional behavioral health authorities to allow local needs to be met by allowing that any appropriations of behavioral health regions be used within an approved annual budget or by activities that are identified through needs as demonstrated through the regions. If there ever was a time to make sure that all resources that are available be directed to services, it truly is now. And I know in the past, we've come in and supported the regions when they've simply asked for intent language to be included in the budgets, just trying to make that point of, we need this flexibility. We understand the needs of our community. And if the resources are there, let us direct them to where they need to go. So I truly thank you for your attention and hope you will see the merits of LB 433 and advance it to general file.
Thank you for your testimony. Are there any questions from the committee? Senator Kavanaugh.
Thank you. Thanks for being here. You said in 2004 there was a bill passed.
That was one of the big reform bills, 1083.
1083. I didn't catch the bill number. Thank you. Do you have any comments you'd like to make to address this fiscal note?
Death by fiscal note. I have had personal experience with that as
yes,
well.
I know.
And I haven't had to deal, I haven't looked in depth at the fiscal note, but
one of the things that it talks about is needing additional FTEs to ensure federal compliance. And that's something you heard me probably ask already. It just feels like they should already be doing that.
They are. And I mean, I've heard from my members all the time about the amount of information that they're required to provide to the regions, so the regions can then in turn, submit, their reports and the audits. So I can't think of anything, and I've never heard any of my members say anything that would make that requirement necessary.
Thank you.
Senator Reed.
Thank you, Chairman Hanson. Welcome back, Senator.
Thank you.
One of the questions, and I know we've sort of targeted DHHS on this, but are they getting additional federal push down from them for changes that they're just simply the go-between but they're catching the flack on it?
I can't speak to that specifically. I have not heard anything to that degree. Again, there's truly an understanding of these are the federal dollars and these are how the federal dollars have to, and my members understand that as well. So they're always on top of it. So as far as would there be pushback from the federal government, I can't imagine that there is.
We might get a chance to hear one on coming up. I don't know, but thank you very much.
Yep. Any other questions? Seeing none, thank you.
Thank you.
Is there anybody else wishing to testify in support of LB 433? All right, seeing none, is there anybody wishing to testify in opposition? Good morning.
Good morning, Chairman Hanson and members of the Health and Human Services Committee. My name is Bo Botelho, B-O-B-O-T-E-L-H-O. I am General Counsel for the Department of Health and Human Services. I'm here to testify in opposition to LB 433 on behalf of the department. DHHS administers and coordinates the state's public behavioral health system. This includes prioritization and approval of expenditures of behavioral health funds and coordination and oversight of regional behavioral health authorities. DHHS takes these responsibilities seriously and works throughout the year with the regions to ensure the budget and subsequent budget changes are supported by revised budget information, service utilization, and other data. Approved budgets and expenditures are based on annual budget plans submitted by regional governing boards. The budgets are reviewed by HHS for alignment with the state's strategic plan. Budget guidelines are provided to the regions each January for use during budget plan development. HHS monitors and ensures compliance with federal maintenance of effort, match requirements, and the funding proposals set by the legislature and federal entities. Without this oversight, the state risks failing to meet its maintenance of effort obligation, resulting in loss of federal funds. While DHHS supports full expenditure of allocated funds, the complexities of multiple funding sources and the requirements must be weighed in all decisions. Automatic reassignment of funds could lead to audit findings and federal disallowance of funds. Changes to approved budget plan can be proposed throughout the contract period and are evaluated based on budget justification and demonstration of need. In fiscal year 2022, the first 6 months of fiscal year 2023, the regions asked for a combined $5.6 million in budget changes, all but a few thousand dollars. I think it's around $4,000 was approved. DHHS works diligently to review and approve the request within 4 days, consistent with the agreement with the regions. The bill would also grant the regions the right to request an administrative hearing if a budget request is denied. It is inappropriate to use the Administrative Procedures Act, the APA, hearing process for matters relating to intergovernmental funding agreements. A decision regarding the requested budget change for grant funds doesn't rise to the level of a contested case involving individual rights. The hearing officer and the district court are not the right places for these decisions to be made. DHHS understands the need for government to be flexible and responsive. HHS will continue to carry out the intent of the legislature and the federal government and be a good steward of public funds. We ask that the committee now advance LB 433. And I'll try to answer any questions.
Thank you for your testimony. Are there any questions? Senator Reapy.
Thank you, Chairman. I'm accustomed to having DHHS come generally in a neutral capacity. So you obviously feel very strong in coming in an opposition position. And my question, I guess, would be is, and I briefly looked here at the fiscal note. Correct me if I'm wrong here. It says the addition of 10 FTEs would be used for contract, sub-award management, and monitoring the agreements. That seems like a kind of a concrete block to make the person drowned, if you will. It makes it, the fiscal note then tries to kill it, as Senator pointed out. I hope that's not the case. You're telling me it's going to take 10 FTEs to administer this redistribution of 20%.
I think what the Division of Behavioral Health is saying that if we're going to manage each region independently, they're not staffed to manage multiple, basically separate, distinct, almost like a confederacy of behavioral health districts. They're staffed to manage a statewide enterprise, and that's how they're operating. The intent is to separate them all, and now we're managing them all individually. Then these FTEs is what they're saying they would need to set up basically independent units.
Aren't you managing them independently at this time?
The way behavioral health works is they're almost like air traffic control tower with the funds. We have a maintenance of effort, which is different than a match requirement. So the state is required to spend so much state dollars annually for specific purposes in order to maintain federal funding, these block grants. So what they're doing is they're ensuring that the overall spend is meeting this maintenance of effort match to preserve the block grants. And they're doing it as a collective, which is when we're shifting money around, they have to ensure that they're maintaining their maintenance of efforts for the totality for the state. But they're not seeing each region as sort of like an independent entity where they would have their own maintenance of effort. They're looking at it collectively, is how I understand the process. I'm not in the Division of Behavioral Health, but that's my understanding of the process.
So you wouldn't be comfortable if the executive director of each unit attested to the fact of how they spent their 20%. It almost gets to a trust factor.
It does, and the accountability in the federal government is always with the state, because the money is given to us, and we are then awarding it to the regions When they come back for the money, they're coming back to us, state level. They're not going to the regions and saying, you failed to meet the maintenance. And that's not how we're set up. We're set up that when the feds look down on us, they see one state enterprise. They're not necessarily seeing it dividing into regions. So ultimately, the responsibility falls on us to ensure that maintenance of effort is met, to ensure future federal block grant funds and any match requirements are being met.
It appears to me that the feds might have more flexibility than you're having at DHHS.
When it's their money, it's their rules, and we're just complying with their rules.
Okay. Thank you, Chairman.
Thank you, Mr. Botello, for being here. In your testimony, you said that the department at the regions asked for a combined 5.6 million in budget changes, and all but a few $1,000s was approved. Not to get too much into semantics, but what is a few thousand? Because a few
4,000.
4,000? Okay, so we have kind of a conflict here in testimony because we had the very first testifier in support, Kathy Seacrest, said that they had over $300,000 that they were seeking approval on that they haven't been able to use.
So the numbers I was speaking about are budget shifts, which would be shifting within approved budgets, is how I understand that works, Senator. I'm not sure what the first, it may have been original budget or it may have been new services.
Okay.
Which one of the previous testifiers spoke about that as well.
Sure, we can probably circle back on that offline.
Yes.
That was just stuck out to me. The fiscal note and this insurance of federal compliance, I know you just kind of discussed this with Senator Reapy. I am having a difficult time understanding what it is you do now and how this would be different, because it seems like now you have to, correct me if I'm wrong here, have federal compliance, and you have to ensure that the dollars that they're spending are federally compliant. How would this require 10 additional people? I guess, let's go back to before 3 years, 7 years, whenever it was that this shift came in the contracts. Did the department eliminate 10 FTEs at that point in time? If you previously allowed the flexibility to do this 20% shift in spending, when you eliminated that from the contracts, did you also eliminate 10 FTEs from the Department of HHS?
I don't know, Senator, to be honest with you. I'm not sure. My understanding of the changes in the contract that's been testified to are changes to ensure compliance with our federal block grants.
Okay.
I don't think there was an elimination of FTEs that I'm aware of.
Okay, because there seems to be a disconnect in how the department is presenting this versus how the regions are understanding it. And part of this disconnect seems, and again, I would like you to speak to this, to be a lack of communication. It sounds like from what they have said that they have tried to have communication with the department, and even Senator Jacobson has tried to have communication with the department, and there wasn't clear lines of communication, which has brought us to this point today. Can you speak to that?
To the extent Senator, actually what I know is what Senator Jacobson has told me in conversations and what he testified here today. So I don't know all of the history. The communications they're talking about are between the regions and behavioral health. And Director Green was not able to be here today, but I know that he has met briefly with Senator Jacobson and has committed to continue to meet with him and try to resolve these issues. But I agree with you that there appears to be a communication failure between the division or the department in these individual regions. But I don't know the genesis of that, and I don't know what the obstacle is.
Okay, so sorry, bear with me for just one more minute. So you've spoken with Senator Jacobson in advance of this, and has this fiscal note been discussed and how we could address the fiscal note? Because the fiscal note, as far as I can tell from all of this testimony, is a lack of communication in what the intention of the bill is, what the intention of the regions are, and what the expectations are, both federally in compliance and just the state generally. There seems to be a lot of lack of communication. And to Senator Reepe's point about departments coming in opposition, I think Senator Reepe and I served our first 4 years in a very different environment. I am very used to the department coming in opposition, unfortunately. But it would be great if we could have less of that and more upfront communication. So is that something that happened and there just couldn't be an agreement, or is that something that has not happened?
I have not spoken with Senator Jacobson about the fiscal note.
Okay.
But I think the fiscal note is based on what the department is. The department is not sure how we would manage this under this bill, what the expectation of the legislature is, how you want us to manage these regions under this legislation. So they're assuming that they're going to be independent. And now we're basically going to have a division of behavioral health for each region almost to that effect. And so I think that's the
Sure.
basis of the note.
My note to the department would be to perhaps before you formulate the fiscal note, to have a conversation with the introducer to find out the intent and see if there's some work that can be done in advance so that we don't have these conversations. But thank you.
Any other questions from the committee? Senator Walls.
Question. Thanks for coming today. So if we would remove the federal funds and appeal, would you come in support of the bill then?
I'm sorry, Senator, I didn't understand that question. If we would remove the federal funds?
Yeah, I thought.
So a lot of this has to do with the maintenance of effort, which we
Right.
have to use state dollars. Now, if you're going to say that we're going to forego any of these block grants, and we're basically going to say we're not going to seek federal funding for any behavioral health services in the state of Nebraska, then that would shift a lot of money over to general funds, and you're going to have a huge general
Right.
fund impact.
Right.
But I don't think that's what you're asking me. Is it, Senator?
No. No, it's okay. I'll circle back with you on that. Can I ask one more question though, please? Thanks. Here's another silly question. Because I don't know. When you are preparing fiscal notes, is there consideration on the overall state budget? Like when you're coming up with these fiscal notes, how are you considering how it will affect the overall budget? Does that make sense?
So when we do a fiscal note or fiscal impact statement, we look at the legislation and we look at what costs that would be, or new costs, especially if it's new work, right? Which in this bill, it's unclear if we're going to be having to do new work under this legislation. So we look at what the cost is to implement the bill and put it in the fiscal impact statement. We have to look at each individual bill separately and do a fiscal impact for each legislation.
Right.
You will see lots of impact statements where we say that we try to quantify the work and then say, this bill, we can absorb this cost. But then the concern is if a lot of these bills drop that we're saying we can absorb the cost, then we may have costs now that we can't absorb. But that's the way the fiscal note works. You have to look at the legislation in a vacuum. What is the cost to implement this bill? And we estimate that cost.
Okay. I understand. Okay.
Because we don't know which bills at the end of a session are going to be enacted into
But you're
law.
saying you can absorb this cost.
No, we're saying that if we're unclear on how we're being asked if this bill passed to implement this. But what the Division of Behavioral Health is saying is that if they have to, in essence, manage each region separately, I believe, almost like independent behavioral healths, then they're going to need additional staff because they can't do that with their existing staffing. They can't do all the monitoring if they're all a separate individual entity and we're not looking at one strategic statewide plan where we're managing a statewide system of services. We're now managing multiple individuals. basically splitting the division of behavioral up into regions as well. And again, I'm not in the division of behavioral health, but reading the fiscal note, that's what I think they are preparing to do with this legislation.
Okay, thanks.
Senator Ballard.
Thank you, Mr. Chairman. I want to get away from the fiscal note for a little bit. You said in your testimony that review of approval and requests take about 4 days. That's your goal.
That's the goal, yes.
We've heard from multiple testifiers that that's not the case, that this isn't, I think Region 5 said they averaged 78 days. So it doesn't sound like a one-off. So can you take me through the process of how you review those requests? And taking into consideration, the CEO came in a few weeks ago, talked about innovation. That's not very innovative, in my opinion. Not very business-like. I know I'm just a humble pastry chef, but if I ran my business like where I waited for customers for a long time, then I won't have a lot of customers. Can you talk a little about that process and what you can do?
I'm not sure what the behavioral health process for these requests are. I know there are different types of requests. In my testimony, I was speaking about requests for cost shifts, which I think are very different than some of the requests that the regions are asking, like bringing up new services. So there are a different variety of types of requests that may require different levels of approval, but I really don't know, Senator. I'd have to get back to you on that. I can get that information from the division and provide it to the committee.
Okay, thank you.
Any other questions from the committee? All right, seeing none. Thank you.
Thank you.
Is there anybody else wishing to testify in opposition to LB 433? All right, seeing none, is there anybody who wishes to testify in a neutral capacity? All right, seeing none, we'll welcome Senator Jacobson up to close. And for the record, we did have 6 letters in support of LB 433.
Thank you, Chairman Hansen and members of the committee. I'm trying to figure out where to begin here on the close. I think what you heard what was happening on the ground. I think you heard what was happening from the standpoint that we've got people trying to serve people within the various regions of the state to do what they were set up to do originally. And yet there's roadblocks. I'm not quite sure on this last testimony in terms of dollars that have been approved, but I can tell you last September, Region 2 was not able to expend $1.2 million and they had to forego those funds. I would like an explanation from the last testifier why that happened. $1.2 million. I'm going to go back to Senator Kavanaugh's question. Thank you for the question. Why did we need 10 people now when we didn't get rid of 10 people back in 2015? Because I'm looking at the budget or the contract that was signed with the department with Region 2 back in 2015, and it said, with the exceptions identified in section E, paragraph 2 and 3, the region is permitted to reassign funds within service categories up to 25% of the funds between service categories without prior approval of DHHS. We did it back then. I'm insulted that DHS came here and testified in opposition. That's inappropriate. They should have been here in a neutral capacity sharing their information. Very frustrating how this is working. I know they've got a tough job. I appreciate the job they have to do. But I'm sitting on the ground watching the actual providers struggling to try to curb the mental health issues that we're dealing with across Nebraska. We listened last year at LB 920 trying to look at prison reform. What do you think's feeding our prison system? We got to get on the front end of these things. And 78 days for a response is unacceptable. We can't do that. This flexibility is needed to make that happen. This is not a coup d'etat. We're not trying to overthrow anybody. We're trying to get flexibility within the funding that the state is putting into this program. And they're notifying DHHS of what they're doing so they can run their numbers. Again, the fiscal note, insulting. Absolutely insulting. Let me also give you just one piece of the track record. This conversation I had, the letter I sent, email back, the letter back and forth is back in September. I was told no flexibility because of the contract. No flexibility. Communication since that time? Zero. Zero. When did I have conversation with DHHS? A week ago. When did I get the fiscal note? This morning. Is that cooperation? Is that trying to solve the problem? Don't think so. Not how I interpret it. I've got a good memory. I'm going to remember this day. Thank you, and I hope you'll move this bill forward. Do the right thing. I'd stand for questions.
All right, thank you. Are there any questions? Senator Kavanaugh.
Thank you. Thank you, Senator Jacobson. Not so much a question as more of an observation. When the department comes in with fiscal notes like this, it is not constructive and it is not helpful to future fiscal notes to be taken seriously. So it does make it difficult for our jobs in any state agency. I appreciate very much your frustration. For 4 years, I think every bill that had anything to do with the Youth Rehabilitation Treatment Center had a $4 million fiscal note because they interpreted that we wanted to bulldoze buildings. And anything that touches CMS had a, was it $40 million fiscal note because we need a new computer system. So it does make our jobs difficult, and I very much appreciate your perspective on this. I do think that there are a lot of questions that we couldn't get answered in this hearing as a result, and it would be helpful if you could give us copies of those contracts to look at the history of it. So thank you for bringing this bill, and I'm sorry for this frustration.
And by the way, we agreed on this issue. Now, we aren't going to agree on all issues, but
Again,
but you've got this one.
I hope somebody is cross-stitching everything from today. So,
All right, any other questions? Senator Reapy.
And just for the record, I want to clarify a little bit. I'm not in opposition of coup d'etats.
That's good. That's good to know.
They have their place.
They do. Thank you, Senator Reedy.
Any other questions? All right, thank you for
Thank you.
coming. Thank you for closing. And now end the hearing on LB 433. And we'll move on to LB 219 and welcome up Senator Ibach.
Thank you, Commissioner.
I feel like I have to adjust my glasses because I'm sitting. We need to get some books.
Yeah.
Pillows. Or for that chair. Maybe just
Or
one.
just taller senators.
Oh, well. Lord, that ain't gonna happen.
All right. Well, welcome to HHS, and if you are willing or ready to open whenever you
This one's gonna be much easier. Good morning, members of the Health and Human Services Committee. My name is Senator Teresa Ibach, Teresa Ibach, and I represent Legislative District 44. Today, I'm here to introduce for you consideration for LB 219. LB 219 is a simple bill which directs the Division of Medicaid and Long-Term Care to rebase inpatient interim per diem rates for critical access hospitals using the most recent audited Medicare cost report. As of now, there are 63 critical access hospitals in Nebraska. For background, the critical access hospital designation was designed in 1997 to keep access to healthcare viable in rural areas across the United States by reducing the financial vulnerability of rural hospitals. To be eligible for the designation, hospitals must meet the following criteria. They must have 25 or fewer acute care inpatient beds. They must be located more than 35 miles from another hospital. They must maintain an annual average length of stay of 96 hours or less for acute care patients, and they must provide 24/7 emergency care services. There are 6 of these hospitals in my district, District 44. Chase County Community Hospital in Imperial, Cozad Community Health Systems, Dundee County Hospital in Benkelman, Gothenburg Health, Lexington Regional Health Center, and Perkins County Health Services in Grant. The Nebraska Hospital Association recently released a report that stated that 53% of our critical access hospitals are currently facing financial stress. While there are numerous reasons for these hospitals to have this financial stress, I believe that by enacting LB 219 into law, we can help alleviate one of these pressure points. Critical access hospitals are reimbursed based on their cost of providing services. Currently, the average patient cost for Medicaid recipients who receive services in a critical access hospital is between $3,300 and $4,500. Medicaid then will pay a per diem between $1,800 and $2,600, which only covers about 50 to 60% of that cost. This is the part that the bill would direct to be rebased. This per diem payment is artificially low and should be updated to better reflect today's costs. Additionally, these critical access hospitals then have to wait 18 to 24 months for full payment of the remaining costs already incurred to provide that care. When the states only pay 50% upfront, then these small hospitals are stuck holding the bag on the remaining 50% for up to 2 years. We can help our rural hospitals simply by retiming these payments. Paying a greater amount of the Medicaid costs upfront allows those hospitals financially struggling to retain existing services and staff, and may allow those that are in a stronger position financially to expand their services, which then keeps our rural communities strong and healthy. After a discussion with the Department of Health and Human Services, I am submitting for your consideration AM 33, which will amend LB 219 to require the department rebase the interim per diem rates every 2 years, as opposed to the every year annually that was proposed in the bill. And this is due to the complexity and increased workload needed to rebase these rates every year. With that, I'm more than happy to address any questions. However, I do have some testifiers that are more proficient with the answers than I will be. So thank you very much.
Thank you for your opening. Are there any questions from the committee? Senator Kavanaugh.
Thank you. I just want to know, how did you get such a pretty fiscal note? I'm kidding.
Pretty or?
Well, I mean, it doesn't require, it's reasonable.
It's really like just for additional staff
Right.
to rebase.
Yeah.
And I think someone will testify, but currently I think the Fed rebases every 4 to 6 years maybe.
And this would be annual?
Yeah.
Thank
Well,
you.
this would actually be biannual. So
Biannual.
they would rebase every 2 years.
Okay.
We requested 3, or we requested 1, they proposed 3, and we compromised at 2.
Okay.
So.
Thank you.
Sorry.
Any other questions? All right. Seeing
Thank
none.
you.
See it closed. All right, we'll take our first testifier in support of LB 219. Morning, Manny.
Good morning, and I am short. Good morning, Chairman Hansen and members of the Health and Human Services Committee. My name is Manuela Banner, Manuela Banner, and I'm the President and CEO of Memorial Community Hospital and Health System in Blair, Nebraska. I'm here today to testify in support of LB 219 on behalf of CHI Health, the Nebraska Hospital Association, and the Nebraska Rural Health Association. When critical access hospitals are not reimbursed in a timely manner, it can have negative impact on the financial stability of the hospital. We have operating expenses such as salaries, supplies, and equipment that need to be paid on a regular basis. When our reimbursement is delayed, it can put a strain on our cash flows and make it difficult to meet ongoing expenses. It can also lead to decreased morale amongst our employees in an already very tough labor market currently, affect the overall stability of the hospital and the reputation of the hospital in the community. There are 63 critical access hospitals in the state, and more than half of them report that they've been operating with a negative margin for several years. I have a personal example from my days in a previous role in Nebraska. At that facility, every morning, our CFO and I would meet and look at our receipts from the previous day and our bills that we had to pay for the month, and we would decide based on our receipts what we could pay in the morning. And every month, when payroll came around, we weren't sure whether we would be able to meet those obligations. All this happened at a time when we were paid a lower than necessary per diem from Medicaid, and then we would have to wait 12 to 24 months to often longer to receive our end-of-year settlement. As in many other industries, our costs have skyrocketed, but the Medicaid per diem has not been adjusted. Specifically, in the last 2 years, we've seen an average increase in costs of about 33%, much of it related to labor costs and supply chain issues. Today, I'm not here to ask you that you pay us a higher reimbursement. I'm not looking for a raise. I'm here to ask for support that the critical access hospitals in Nebraska receive timely payments from Medicaid. Your support could help in providing a quicker availability of these funds that already show in our books as a receivable and in your books as a payable. Let me explain. Currently, critical access hospitals receive a per diem rate within about 8 weeks after a patient's stay. This per diem rate actually reflects only about a third to a half of the actual amount due to from Medicaid. Annually, there is a truing up of charges. This is generally done at the end of the fiscal year, and the hospital report the difference between the actual cost and the payment received. Medicaid then is supposed to settle up with us with the remaining payment. The main and most driving issue is that currently the settlement takes between 12 and 24 months and sometimes longer. These are long months that especially put the 53% of hospitals that are currently already operating at a financial risk at even a higher severe stress. Critical access hospital payment is difficult to understand for many. Even our CPAs on our board sometimes don't understand the cost-based reimbursement. So please forgive me if I make this really simple here in a different example. If I were to get the engine replaced in my car and paid the repair shop the same amount it cost to replace an engine 5 years ago, let's say $1,000, and at the end of the year, my car mechanic would notify me that I owed an additional $1,000 to $2,000. If I handled it like Medicaid true-up, it could take up to 24 months for me to pay the rest of the cost of the repair. If this is how repair shops work, we would have a hard time finding a place to fix our car. I'm here to support this legislation to reset the base amount received by critical access hospitals from Medicaid based on the actual cost of a facility from the prior year. Hospitals file a Medicare cost report annually. This report reflects the current and actual costs, so the rate set based on this cost report would reflect the most up-to-date cost of care for each patient. This is already in practice by our Medicare payers. If this was done annually or biannually for Medicaid based on actual cost in the prior year, hospitals would receive reimbursement in a much more timely manner, and better yet, at no additional cost to the state. The money is already owed, so timely payment only reflects a much more realistic payment timeframe. Quick turnaround of appropriate Medicaid reimbursement may mean the difference between remaining open and solvent and closing their doors for some critical access hospitals in the state. It's important for critical access hospitals to receive timely reimbursement from Medicaid to ensure that they can do what we like to do the best, and that is provide high quality care to our communities. Do you have any questions?
Thank you. Mandy and her husband always beat us in trivia night once a week. And so if anybody has any really difficult questions to ask her,
It's my husband, and
now would be the time to do it. Now, are there any questions of the committee? Yes, Senator Reapy.
Sounds like you're a person that has a lot of knowledge. If you can beat the senator any gain, I guess. My question is what is your percent of Medicaid?
Our percent in our facility is only 6%.
What?
6.
6? Oh, I would have guessed higher. Okay. The other thing I'd like to have you define, you've talked about an untimely reimbursement. And I think you said 24 months. So you want that to go to what? Not tomorrow, but.
Absolutely. If we got an appropriate base, then it wouldn't be so important for that rebate, for the cost report settlement to come in within a month or two, but it would be nice if we could get it within a few months of the end of the year and time we filed our reports.
Okay. And I think you mentioned in your testimony that critical access hospitals are on a cost plus basis. Now, I assume maybe there's some cost in there that don't apply, but for people that are on a cost plus, they're probably not too sensitive. And I hope that I see the hospital associations here. I have a question for them that if Mr. Hale does testify, no, he says he's not going to. Then I have been told by a credible source, a former state legislator who of course never exaggerate or lie, that in the Ogallala area, there are 2 critical access hospitals within 15 miles.
I can't speak to that.
Yeah, that's why I'll catch him in the hallway later. If it is, that to me is a concern, because this is like many things, once established, takeaways are next to impossible. Policies, payment methodologies, you name it. Once given, that's why we have to be very prudent about what we do give away. Thank you.
Any other questions from the committee? No? Seeing none.
Thank you.
Thank you for your testimony. Now we will take the next person to testify in support of LB.
Oh, well.
Welcome.
I hope I bullied you into this.
I think you did. Chairman Hanson, members of the committee, my name is Andy Hale, ANDYHALE, and I'm Vice President of Advocacy for the Hospital Association. I do want to thank Senator Ibach for bringing this bill and having Manny come and testify. We do have Wade Eschenbrenner, who is from Lexington, who is a CFO, who can answer probably some more pertinent money questions. But Senator, to your question, Ogallala, Nebraska is with Banner Health, and they are there's not another hospital located within 15 miles. It would follow the regular hospital.
So this legislator lied to me.
That I can't comment on because I think he's my boss. So I don't know, maybe if there was some misinformation, I wasn't privy to that conversation.
It was a different one.
Oh, a different one. Okay. So to my knowledge, no, and I'd be willing to meet with you and that certain individual as well.
We'll get you under oath.
Yeah, I have not sworn under oath today, nor am I going to as of yet. But no, I can tell you that is not the case.
Okay.
All right. Any other questions from the committee? Yes, Senator Repeat.
Do you feel that thank you, Mr. Chairman, do you feel that we as legislators have the authority to establish the timeliness of reimbursement? I'm concerned about that. It seems that goes to the federal level as much as it does to the state level in terms of who can say you have to pay within 30 days.
I think if you worked with the state Medicaid department, I think they can help you with that. I agree, we're not forcing someone to pay, but in reality, these payments usually occur, as Manny stated, and I think Wade will too, 18 to 24 months. And so, again, this isn't new money or that's coming out of the state. The state has this money. My understanding, it's coming here to the state and they're holding on to it instead of moving it. So when you asked a time frame, I think anything would be better than they currently have.
I think in your response, you're delegating up. Yeah, I would say, I would push back and say, as a hospital association, you need to be in the mix on that and negotiate that, not us as a legislative body. I mean, we're not in the business of doing that.
We've had conversations with Medicaid. I don't believe they are here.
You can go ahead and say anything now.
I think we're still on TV and being recorded. So, we've had conversations and we've worked with them on this. Again, that's probably something we can talk to together on how that procedure works. And
How long have you been at that?
the communications with them?
I mean, it doesn't sound like it's within the last 30 days you've had that discussion.
Oh, we had this discussion, I believe this summer in the fall with them. They knew that
For the first time.
In my time there, that was the first time we talked
And this
about
is unique to all of the 63 critical access
Correct.
hospitals. Okay. Thank you. Thank you, Mr. Chairman.
Any other questions? All right, seeing none. Thank you.
Thank you, Senator.
All right. Take our next testifier in support.
Welcome. Good morning. Good morning, Chairman Hansen and members of the Health and Human Services Committee. My name is Wade Eschenbrenner, WadeEschenbrenner. I'm the Chief Financial Officer for Lexington Regional Health Center. I'm here today to testify in support of LB 219. As kind of previously described, the Medicaid reimbursement model is based on a cost-based reimbursement system. And as you had mentioned, it's not necessarily 100%, right? 90% of our costs are considered allowable, 10% typically aren't. So that's kind of our starting point from a cost-based perspective, which reimburses our cause for reasonable and necessary costs incurred in providing care to Medicaid beneficiaries. The amount of reimbursement a CAW can receive is determined by various factors, such as hospital operating expenses and amount of Medicaid patients served. The aim of the reimbursement model is to provide adequate funding to CAWs to help ensure their financial stability and continued operations. We are currently carrying, as Lexington Regional Center, 9 days of operating cash and Medicaid receivables waiting for settlement. That approximately $1 million of Medicare or Medicaid receivables going back multiple fiscal years. We are still working with one HMO on a pre-pandemic settlement in 2019. Reducing the Medicaid receivables a hospital carries will allow us to better plan equipment, supplies, and other operating purchases instead of trying to coordinate it in the timing of settlements. If a CAW is building up their cash reserves for future equipment and repairs, the lost opportunity of that investment income could be more than $40,000 annually for a CAW. As we continue to see high inflationary pressures, our costs of today are much higher than they were 18 to 24 months ago. Particularly in a time of nurse shortages, respiratory therapist shortages. We heard Paul Dongilly talk about their Medicaid, it's respiratory intense, and we have the same issues in CAW hospitals. These shortages are reflecting this increase. Rebasing is one way to help alleviate these pressures. It is important for CAWs to receive timely reimbursement from Medicaid to ensure that we can continue to provide high quality care to our communities. So it's not asking for more money, it's just the timing of the money. So we get interim rates from Medicaid, which are not reflective of the true cost. So as Manny kind of described, we go through the fiscal year. At the end of the fiscal year, we submit a cost report to Medicare 5 months after the fiscal year end. And then that's how we determine the cost for the year. That gets settled with Medicare and with Medicaid.
All right, questions. Thank you for your testimony. Are there any questions from the committee? Senator Repeat.
Thank you, Senator. What's your percentage of Medicaid?
It depends on what service, but generally, overall, we're 15%. We're one of the higher Medicaid population CAWs in the state. We have the lowest Medicare percentage in the state.
On your community benefits report, which you're required to file, how much of that is charity and how much is bad debt?
We're actually a district hospital, a political subdivision, just so you're aware, so we don't
Do you have
follow.
county support too?
We do not levy any taxes.
Okay.
So we don't do
you
a
have
five.
Feel for what you give it. Charity, we always said the ones that would like to pay but can't.
Yes.
And the bad debt are the ones that could but choose not to.
True. We approximately have 250,000 to 300,000 annually in charity care and
Okay.
approximately 2 million in bad debt.
Okay. Okay, thank you. Thank you very much. Sure.
Senator Kavanaugh.
Thank you. Thanks for being here. In your testimony, you made a comment that I'd like to dig in on a little bit more. You currently have a 2018 HMO settlement?
2019.
2019. Can you tell me a little bit more about that?
It's one of the plans that exited previously. So I think it just in discussions, it took a long time to figure out who to talk to at that plan.
Okay.
And so we're currently working through that. They kind of were unaware, I think, that this.
So you have a settlement with a previous HMO.
Correct.
Can you share any of the details about that?
WellCare exited, Healthy Blue came in and took their place.
Okay.
So it's with WellCare.
And for how much?
It'll be hard to determine. I can't give you an exact number because it'll be based on their records.
Okay.
In essence, it's probably for the last, they exited in January. Our fiscal year is June 30, so there's a 6-month period. Could be $50,000 approximately.
50,000?
Approximately, that's just my guess.
Okay. Okay, so thank you.
Any other questions from the committee? All right, seeing none, thank you for coming.
Thank you.
Is there anybody else wishing to testify in support of LB 219? All right, seeing none, is there anybody who wishes to testify in opposition? Seeing none, is there anybody who wishes to testify in a neutral capacity? All right, seeing none, we will welcome up Senator Ibach to close. And for the record, there were 4 letters in support of LB 219.
Good. Well, this will be really short. Thank you again for your attention. I would just note that the bill really does just address the rebasing, but we did meet with Mr. Bagley and he agreed that they could adjust the timeliness of their payments. So we're going to follow up with him and stay on that. So that's
Any
all I have.
questions? You were brave to start off your opening saying, "This is a simple bill." I've learned never do that.
So that's your advice?
Yeah, it's just a simple bill. All right, so with
Thank you
that,
all very much.
Yeah, I'm just crossing that out on my testimony.
that will conclude our hearing for LB 219, and we will welcome up Senator Ballard to open up an LB 458.
It's a simple bill. I crossed that out. Still say good morning.
Welcome.
All right. Thank you. Good morning, Chairman Hansen and members of the Health and Human Services Committee. My name is Bo Ballard. For the record, that is Beau Ballard. I represent District 21 in Northwest Lincoln and Northern Lancaster County. I'm here today to introduce LB 458. LB 458 eliminates regulatory barriers in healthcare and increase the cost and decrease efficiency. LB 48 provides clarity in the existing definition of central fill pharmacies. Central fill pharmacies preparing and packing prescriptions on behalf of dispensing pharmacies, allowing pharmacists at the dispensing pharmacy locations to spend more time focusing on providing direct patient care. LB 458 proposes 2 changes. The first, to provide clarity that when a central fill pharmacy and a dispensing pharmacy are under common ownership, the central fill pharmacy can deliver prescriptions to the patient on behalf of the dispensing pharmacy. Right now, the regulatory interpretation of the existing definition of central fill requires that prescriptions that are filled in a central fill pharmacy be delivered back to the dispensing pharmacy location before it can be delivered to the patient. For patients who wish to have their medication delivered to them via mail or courier, this is an extra step requires additional resources and time without adding any value and improving patient safety. It also adds a delay in patient receiving their medication. The updated central fill definition proposed in LB 458 will eliminate the requirement to return the prescription first back to the dispensing pharmacy before delivered to the patient. if the delivery is what the patient prefers. The second change proposed in LB 458 is to remove the requirement that the central fill pharmacy number be included in the prescription label. Since the dispensing pharmacy maintains the primary patient-facing responsibilities, it can add confusion for patients by including the phone number of both the dispensing and the central fill pharmacies on the prescription label. By removing that requirement for inclusion of the central fill pharmacy's phone number, it will provide clarity for the patient that the dispensing pharmacy is a number that they can call for questions and needs. This bill was brought to me by Nebraska Medicine, and they intend to clarify some additional testimony to move this simple bill forward to general file.
All right. Any questions from the committee? All right, seeing none, we'll proceed to close. We'll welcome up our first proponent testifier. Welcome.
Hello. Good afternoon, Chairman Hansen and members of the Health and Human Services Committee. I am Sarah Kuhl, SARAH-KUHL. I'm Director of Community-Based Pharmacy Services at Nebraska Medicine, which is a nonprofit integrated healthcare system. Our healthcare network includes 2 hospitals, Nebraska Medical Center and Bellevue Medical Center, and nearly 70 specialty and primary healthcare centers in the Omaha area and beyond. The healthcare sector is experiencing significant staffing shortages, and the pharmacy workforce is stretched thin. Nebraska Medicine is working hard to identify ways to utilize resources as efficiently as possible while maintaining our high standards of care for patients. One of those opportunities for greater efficiency is the addition of our central fill pharmacy. The Nebraska Medicine Central Fill Pharmacy prepares and packages prescriptions for patients, which allows our health system to more efficiently deliver prescriptions to our patients. Our Central Fill Pharmacy allows pharmacists at our patient-facing pharmacy locations to spend more time focused on providing direct patient care. The automation utilized in our Central Fill Pharmacy can fill about 250 prescriptions per hour, which is about the number of prescriptions that a handful of pharmacy employees can fill in an entire day. Central Fill allows us to take the human resources that are no longer required to fill prescriptions and focus those efforts on providing patient-facing support, such as medication counseling, injection training, triage of acute medication needs, disease state management, and vaccinations. Here is how a Central Fill Pharmacy works. Prescriptions are sent to the patient's pharmacy by providers, or a patient requests a refill. The prescriptions are clinically reviewed by pharmacists for appropriate dosing, indications, and potential drug interactions. After review, the prescription is assessed for eligibility to be filled at our Central Fill Pharmacy. A prescription is eligible for Central Fill if there's adequate time for the medication to be filled and delivered back to the patient's pharmacy prior to the available pickup time chosen by the patient. If eligible, the prescription information is transmitted from the patient's pharmacy to the Central Fill Pharmacy. Technicians at the Central Fill Pharmacy fill the prescriptions with the assistance of the automation equipment, and an on-site pharmacist reviews the filled prescription for accuracy. After that, the prescription is packaged and ready to be delivered to the patient. The existing statutory definition of Central Fill defines Central Fill as where preparation occurs in a pharmacy other than the pharmacy dispensing to the patient. The regulatory interpretation has been that Central Fill pharmacies cannot directly deliver to the patient. For patients who have chosen to have their prescriptions mailed or delivered via courier, this means that the prescription is packaged at the Central Fill location and has to be delivered back to the patient's pharmacy before it can be put in the mail and delivered by the courier. This leads to prescriptions filled late in the afternoon having a whole day delay getting to the patient because they are filled after the courier has taken prescriptions back to the patient's pharmacy for the day. In our case, Nebraska Medicine has had to hire an additional delivery driver and purchase a larger delivery van to meet the requirements to deliver the prescriptions back to the patient's pharmacy before being delivered to the patient. For our Nebraska Medicine couriers, often the same driver is responsible for loading the prescription from the Central Fill Pharmacy, then unloading the prescription at the patient's pharmacy, only to reload the same prescription to deliver it to the patient. LB 458 will remove this burdensome regulatory requirements which require the prescription to be delivered back to the patient's pharmacy location before it can be picked up by a courier service or put in the mail for delivery to the patient. The updated central fill definition in LB 458 will help eliminate potential delays in delivery while allowing us to maximize the opportunities of central fill pharmacy and meet the needs of our patients. This bill reduces regulatory burden and cost and helps address workforce shortages and improves the focus on patient care. Thank you for your consideration. I'd be happy to answer any questions.
All right, thank you. Are there any questions? Mr. Reapy?
Thank you, Mr. Chairman. My question would be, is this the Med Center's response to many of the health plans now promoting pharmacy by mail?
No, not really. We aren't using central fill to increase the mail that we are doing. Our goal is to eliminate as many barriers to care for our patients. So when a patient does need a medication mailed, this allows us to do it more efficiently, but we also need the central fill location just to get those prescriptions for patients who want to pick up. So the central fill is just an efficiency. It's not a way for us to actually increase the mail volume. We are doing it's just to address.
I think we all read about the problems that CVS and Walgreens are having, cutting back on hours, just again, the same problem, staff. I also have a concern, maybe you can respond to this too, is I understand that the incoming class for the School of Pharmacy has been like 100 billets that are open, that they're reading or understanding what's going on in retail pharmacy and they want no part of it. Is that fair to say?
Pharmacy is absolutely a challenging profession to join, and it's rewarding, but also, yes, we are having staffing shortages right now, especially with technicians and with the lower class sizes that we're seeing. We're working hard to address future pharmacist shortages.
Yep. Any other questions? This might be a simple bill.
They told me not to say that.
So really, in essence, and I think how you explained it to me, which I think was pretty good, is what we're trying to do is cut out just a section of the whole process that really makes no sense whatsoever.
Yeah,
So
it's
you have
no
a central
value.
fill, go central fill to the pharmacy, open up the box, and then pretty much shut it again.
Not
Just-
even open the box.
Yeah.
That's not even required.
So it really
It's
makes
literally
no sense.
packaged, taped up, the labels on it, the stamps on it. We unload it, and then we reload it.
Yeah.
So.
Okay. Well, it's almost like how government runs. And just one more thing for clarification's sake, we're looking at taking the phone number off of the labeling, which is fine, but there's still an identifying marker
Yes.
on there about where it came from central fill, right?
Yeah, we want transparency. We want patients to know that this was filled. So the name and address of the central fill pharmacy will continue to need to be on the prescription label. But again, we are doing central fill to open up resources for direct patient care at our pharmacies. And we want our patients to call our patient-facing brick and mortar pharmacies for any questions. So.
All right, cool. And seeing no other questions, thank you very much.
Thank you
Is
very
there
much.
anybody else wishing to testify in support of LB 458? Seeing none, is there anybody wish to testify in opposition? Seeing none, is there anybody wish to testify in neutral capacity? Seeing none, Senator Ballard, you wish to close?
Why not? I've never closed before.
Oh, okay.
No, I just want to, I'll be short. I just want to say this is a great opportunity to promote efficiency and cut some government regulations. As the chairman said, this is a simple bill to do something great for an organization that does so many great things for this state. So I'll be happy to answer any questions or continue the theme of the day, say something nice about Senator Kavanaugh.
Sure, yeah.
Go on.
Any questions? Yes, Senator Kavanaugh.
What would you like to say?
You can see I was just grasping. I wanted one of your famous "You're loved and seen" quotes. That's what
My what?
your loved and seen
Oh,
quotes.
Thank you.
Yeah, of course.
That's good. I like it. Smart. You should compliment her shoes too, always.
She does have great shoes.
Yeah.
Great smile, great shoes.
All right, anything, comments, questions? All right, thank you very much. There were, just to make sure before we close the hearing, there was one letter in support for LB 458. So with that, we will close the hearing for LB 458 and close the hearing for this morning.
My mom bought my shoes at a church sale, by the way, the ones I'm wearing today.